Здесь народ появится, да?
Это
Все.
аудитория, да?
Да, пятая. Мгм. Well, okay. Good morning for who already awakened. Okay. So uh, you see here the topic we'll discuss today: the heart failure. So as usual, we'll start from definitions. It's, I think, the obvious final common pathway for many, not just many, but practically for all cardiovascular diseases whose natural history result in symptomatic or asymptomatic left ventricular dysfunction. And the main clinical manifestations of the heart failure are dyspnea, fatigue, and fluid retention. The annual death risk is from 5 to 10% in patients with mild symptoms, and this death risk increases to as high as 30 to 40% annually in patients with advanced disease. Now we'll consider the pathogenic milieu of the disease process, which we name like heart failure. So, what are the disease processes? Mechanical dysfunction. Mechanical dysfunction leads to pressure overload, hypertension, some kind of valvular stenosis like aortic, pulmonic valvular stenosis, pulmonary hypertension, volume overload, and aortic mitral tricuspid valve insufficiency. Also, it may depend on the impaired heart filling associated with the pericardial disease, ventricular hypertrophy, myocardial restriction, and in some cases with mitral and or tricuspid stenosis. And the causes which may lead to the development of the heart failure are myocardial infarction, cardiomyopathy, myocarditis, some drug toxin-induced problems, and in rather rare situations, systemic disease effects. And this disease process leads to consequent development of the ventricular dysfunction. And this dysfunction more frequently is systolic, associated with the decreased impaired myocardial contractility, and diastolic, with the impaired ventricular filling. The next, hemodynamic abnormalities. Usually we see the decreased stroke volume, decreased cardiac output, and decreased regional blood flow. And also it leads to increased left ventricular and diastolic pressure, pulmonary capillary wedge pressure, right atrial pressure, which are the characteristics of increased preload, and increased pulmonary artery pressure and pulmonary blood volume. These are the characteristics of the afterload. The next, at this point you see the switching of some compensatory mechanisms. Mechanisms are renal. These are the activation of the renin-angiotensin-aldosterone system with consequent salt and water retention. The ventricular compensatory mechanism, you see, these are the dilation of the chambers, predominantly of the left ventricle, and the development of the muscular hypertrophy. And the next compensatory mechanism is the sympathetic activation, which counteracts with the decreased contractility of the myocardium. It's the increased contractility due to sympathetic activation, tachycardia, increased venous tone, and increased arterial tone as well. The next point, you see here the development of the clinical presentations. You see the physical findings with the peripheral edema, in some advanced cases ascites, vascular congestion, jugular venous distension, pulmonary rales, tachycardia, hypotension, and in the terminal stage of the heart failure, cachexia, and show the disease-specific findings depending on the disease which led to the development of the heart failure. The next, symptoms. The symptoms are fatigue and weakness, dyspnea, fluid retention syndromes, nocturia, in some cases gastrointestinal symptoms, and at last diminished mentation. And the heart failure is associated with the development of the metabolic changes like azotemia, hyponatremia, hypokalemia, hypomagnesemia, hyperuricemia, acidosis, in some cases alkalosis, hypoxia with the decreased oxygen saturation, and decreased maximal consumption of the oxygen. The next, it's the endpoint and organ failure and death with the development of renal failure, hepatic failure, respiratory failure, multi-organ failure, pulmonary embolism, and peripheral and more significant, more important, cerebral embolism. And these are the endpoint events which lead to death. Lateral arrhythmia associated with the electrolyte abnormalities, elevated catecholamine levels, ischemia, and at last drug proarrhythmia dependent on the usage of drugs rather paradoxically dedicated to treat arrhythmias, but in some conditions, in high doses, in long-term treatment, these drugs may induce arrhythmia itself. The types of heart failure. Systolic dysfunction or systolic heart failure, the most frequent problem, and more rare problem, diastolic dysfunction or diastolic heart failure. But in many cases, we see the combination of both types of the heart failure, systolic and diastolic as well. Now, you see here the New York Heart Association classification of the heart failure. It divides the heart failure in 4 classes. Class 1. In class 1, we see no limitation of physical activity. Class 2, slight limitation of physical activity. Class 3, marked limitation of physical activity. And at last, class 4, unable to carry out physical activity without discomfort. We use this NUHEI classification widely all over the world. You can find it elsewhere when we consider the heart failure problem. The clinical features. I'd like to say that the making an accurate diagnosis of the heart failure and determining its cause can be difficult, but not really. So, Clinical diagnosis is confirmed to be accurate in approximately half of cases when investigated by echocardiography. And the likelihood of the heart failure in the presence of suggestive symptoms and signs increased if there is history of myocardial infarction or angina, an abnormal ECG, or a chest X-ray showing pulmonary congestion or cardiomegaly. And these symptoms include shortness of breath on exertion. The next, decreased exercise tolerance, often simply fatigue. The next, paroxysmal nocturnal dyspnea, usually we associate it with the orthopnea, and ankle swelling. You can see here the different levels of sensitivity and specificity, but in the real clinical practice, we consider these signs like confirming signs of the heart failure. The most specific signs are the laterally displaced apex speed. What it shows, by the way, it shows that the enlarged left ventricular size is present. The next, elevated jugular venous pressure. Sure, we can see it in the advanced stage of the heart failure. The third, heart sound. We see it also in the very advanced stage of the heart failure. Less specific signs include tachycardia, lung crepitations, hepatic engorgement, tender hepatomegaly, peripheral edema. ECG. Sure, it may show acute ischemia, arrhythmias, left ventricular hypertrophy, left bundle branch block, or the signs of the previous myocardial infarction. The presence of heart failure is unlikely if the ECG is normal, and the diagnosis should be reconsidered in this situation. But by the way, the normal ECG does not suggest that the heart failure is absent. We have to evaluate some additional clinical data. What shows us chest X-ray? Sure, the pulmonary vascular congestion, upper lobe diversion, pulmonary edema, effusions, cardiomegaly, but pulmonary edema, we don't need chest X-ray to recognize it. The clinical picture is enough to see the pulmonary edema development. Okay, chest X-ray. What does it show? You see the cardiomegaly predominantly to the dilation of the left chambers of the heart as well as the right chambers, and here the signs of pulmonary congestion. Echocardiography. Echocardiography is the essential investigation for heart failure evaluation. We consider here the so-called ejection fraction and how we evaluate it. Ejection fraction, it is the relation of the stroke volume to the end diastolic volume of the heart. And how we evaluate it? You see here the four-chamber in diastole and four-chamber view and in systole. And you see here the great difference between the volumes of the heart. It shows us the same for two-chamber diastole and two-chamber systole. You see here the great difference between the volumes of the heart. It shows that the stroke volume is rather high, and the conclusion about the normal contractility of the heart. Nowadays, we have many approaches, instrumental approaches to evaluate the presence and degree of the heart failure. You see here, it's the first pass radionuclide ventriculography, magnetic resonance imaging, MRI, CT, computed tomography, and at last echocardiography. And if you take a look at this table, you see that the many advantages has echocardiography with anatomic relationships, tissue characterization, wall motion, hypertrophy, wall thickening, valvular pathology, hemodynamics, diastolic function, stress exercise, pharmacological stress, and at last the relation between cost and availability. The echocardiography has the very good, it is rather cheap if we can compare it with this investigation, and the results are very appropriate with echocardiography. The next point, B-type natriuretic peptide and its N-terminal fragment, NT-proBNP. It is rather new diagnostic test, not the very new, but very useful investigation. And a raised concentration of either has been shown to have a sensitivity of greater than 90% and a specificity of up to 90% as well for diagnosis of the heart failure. And the heart failure is unlikely if the level of BNP or NT-proBNP is normal, especially if the ECG is also normal, and the diagnosis should be reconsidered in this situation. So, you see here the philosophy of heart failure therapy. In a symptomatic patient, we have to provide the prevention of the development and further progression of the heart failure, to prevent harmful ventricular remodeling and forestall development of symptoms. And in symptomatic patients, we have to provide the appropriate treatment, ameliorate symptoms when present, and reduce mortality. And you see here such a circuit usually we see in the clinical approach when we consider the patients having the heart failure. I think this table is very important. You see here the evidence-based treatment for the heart failure. So, the approaches to reduce mortality include the usage of angiotensin converting enzyme inhibitors or angiotensin receptor blockers, the usage of the beta blockers, and the introduction of aldosterone antagonists. To control volume, we have to provide the sodium restriction and the usage of diuretics. And to treat residual symptoms, we use cardiac glycosides. Digoxin is number one from the cardiac glycosides, but remember that the digoxin is the most useful when the heart failure is supported by atrial fibrillation. And we'll consider this approach a little bit later, like implanted cardioverter defibrillator. CRT means cardiac resynchronization therapy. In some cases, we may introduce the combined prescription of hydralazine as the arterial vasodilator and isosorbide dinitrate. It is the venous vasodilator. And to treat comorbidities, we use antiaggregants like aspirin, we use warfarin like the preventive drugs to embolic complications, warfarin, and as well as the new oral anticoagulants like rivaroxaban, apixaban, dabigatran, and statins like the basic treatment for many cardiovascular diseases. And to enhance adherence for the treatment, we use the education, the explanation for the patients for lifestyle modifications. We have to provide the underlying disease management and performance improvement systems. You see that the star is dedicated for selected patients for whom such a treatment is really indicated. And once more, pay attention that these drugs are essential. ACE or ARBs, beta blockers, aldosterone antagonists, and I'd like to say the diuretics as well. And you see here the tailored therapy for the heart failure for the particular patient. Rather sophisticated table, I'd like to say the timeline. When at the point of the asymptomatic treatment, we have to recognize the symptoms, the diagnosis, etiology, precipitating problems, stage syndrome severity. We have to provide disease-specific therapy, and these are the basic measures like cardiovascular disease risk attenuation, aerobic activity with training, optimization of weight. So the obesity is the very widespread and serious problem which influence on the treatment, on the management of the heart failure, and to restrict the sodium with the usage of potassium, magnesium, vitamin supplementation, fluid restriction from the usual 2 liters to 1 liter per day for intake. Then we repeat here the traditional medications like C therapy, ARBs, hydralazine isosorbide dinitrate, diuretics, potassium sparing thiazide, and the most active loop diuretics combinations as well. Usage of digoxin in the case of the atrial fibrillation, and beta blockers, metoprolol, carvedilol, bisoprolol. Other options in the intolerance for ACE inhibitors and ARBs, hydralazine isosorbide dinitrate. Some doubtful treatment with calcium channel blockers as amlodipine, felodipine, usually to control the heart failure associated with hypertension, rather questionable, and amiodarone to treat life-threatening arrhythmias, like the addition for the treatment of the heart failure. And the treatment for terminal resistant heart failure, we consider the chronic parenteral inotrope therapy, ventricular assistant devices like some bridge to heart transplantation, and left ventricular remodeling surgery, like some kind of substitution for heart transplantation modality. You see here the summary of drug treatment for the heart failure. In asymptomatic left ventricular dysfunction, we consider ACE inhibitor and beta blockers. In the mild to moderate heart failure, we use digoxin, diuretics, ACE inhibitor, and beta blocker. In moderate to severe heart failure, we consider digoxin, diuretics, ACE inhibitor, beta blocker, and spironolactone. I think it is very useful to remember. Some drugs can improve symptomatics, and another drugs can improve survival. Remember, the diuretics and digoxin improve the symptoms of the heart failure, but have no influence on the prognosis, on the survival. Moreover, in some cases, these drugs may induce some kind of arrhythmias, some kind of electrolyte imbalance. And the drugs which improve survival, these are the beta blockers, ACE inhibitors. We also consider together with the ACE inhibitors angiotensin receptor blockers and aldosterone antagonists. These drugs usually have no strict influence on the clinical symptomatics, but we must use them in any case of the heart failure. Remember that our task, together with the improvement of the clinical symptomatics, is the prolongation of the life, so to improve survival. In our days, we have to remember about the newest approaches with the device therapy. This device therapy sure is dedicated for severely ill patients, but these approaches can improve the survival for such patients. We consider here the cardiac resynchronization therapy and the usage of implantable cardioverter defibrillator.
A cardiac resynchronization therapy device, or CRT, is a battery-powered device that sends electrical signals to your heart in a coordinated manner. The CRT device is surgically placed under your skin beneath your collarbone and is connected to your heart by wires called leads. CRT devices are often used to regulate faulty electrical signals flowing through the heart. Bundle branch block is a condition created by electrical signals that travel too slowly through the bundle branches in the heart. This causes the heart muscles of the ventricles to contract weakly. Bundle branch block is common in patients with cardiomyopathy or heart failure. A CRT device is able to detect when the heart is not beating in a coordinated manner. When this type of problem is detected, the CRT device sends electrical signals to the heart to help the ventricles contract in a more coordinated manner. This strengthens the heartbeat and increases the amount of blood pumped out of the heart.
So, cardiac resynchronization therapy, we use,
CRT
you already have heard, we use to control the heart failure associated with the left bundle branch block, where the electrical signal moves through incorrect way, and this approach can correct the truth way of the contraction of the heart chambers. And this approach, it provides the prevention of the life-threatening arrhythmias, which in many cases accompany the end-stage heart failure. You see here this device evaluates the life-threatening electrical activity, but in this case you saw the ventricular fibrillation. And in the case of the ventricular fibrillation, or in the case of ventricular tachycardia, the device makes the electrical discharge, which stops this pathological electrical activity, and at last it simply saves the patient's life. So I ask you, don't forget the presence of such approaches for the treatment of the end-stage heart failure. And you see here, it's the face of the Dr. Christian Barnard, who performed the first human-to-human heart transplantation in the Groote Schuur Hospital in Cape Town, South Africa. More than 50 years passed after this day, and in nowadays, I'd like to say it is not the routine procedure for the treatment of the end-stage heart failure, but in Russian Federation, about 1,000 cardiac transplantation per year are performed. And you see here, it's the typical approach for the heart transplantation when the donor heart, it contains of the ventricles in the lower part of the atria, and the recipient heart contains the partial left atrium. And you see here the reasons for cardiac transplantation in our day. The biggest part of the patients take the dilated cardiomyopathy and ischemic heart disease. I'd like to say the complications of ischemic heart disease, like the previous MI with severe left ventricular dysfunction, aneurysm, and so on. And some other problem like congenital heart defects, like familial cardiomyopathy, peripartal cardiomyopathy, viral myocarditis, and so on. And I like to say it's the very impressive picture of our patient, 57 years old female with dilated cardiomyopathy and with the left bundle branch block you see here. And the contraction of the, I explained, it's the left ventricle, left atrium, right ventricle, right atrium. And the contraction of the left ventricle is very, very poor, with some sponge-like deformation of the myocardium. Is then myocardial non-compaction. The patient, I repeat, had the severe left ventricular dysfunction together with associated with the dilated cardiomyopathy and myocardial non-compaction. And she had the strict indications to cardiac transplantation, and at last it was performed. You see here the heart of this patient after 2 months after the index cardiac transplantation. You see here the normal left ventricle with normal contractility, rather dilated right ventricle and the right atrium. Why? Because it reflects the residual pulmonary hypertension in this patient after the short time after the cardiac transplantation. And very interesting thing, it's the point of stitching of the left atrium here, because this part is the donor part, and the upper part with the pulmonary veins is the part of the recipient heart. And you see here the heart of this patient after 2 years. By the way, she is alive during more than 7 years after the cardiac transplantation, and she feels rather well up to date. And you see 2 years later, and you never can say it is the transplanted heart. It looks quite normal. And a few words about the acute heart failure. Acute heart failure, it includes few conditions. It may be newly progressive heart failure, decompensated heart failure, exacerbated heart failure, refractory heart failure, and end-stage heart failure. And the clinical presentations of the acute heart failure are an acute decompensated heart failure, de novo or chronic, hypertensive acute heart failure, usually dependent on the hypertensive crisis, pulmonary edema, dependent on the acute left ventricular insufficiency. Cardiogenic shock, it's the more advanced condition usually associated with the acute loss of the contractile myocardium, in the case usually of the myocardial infarction. In not so widespread situation, high output failure and the right heart failure. How to treat the acute heart failure? Morphine. Some people think that morphine is dedicated to treat some pain syndromes. At this point, no. Morphine is indicated to decrease the pathological activity of the brain breathing center and to achieve some sedative effect in this case. Vasodilators indicated in most patients with acute heart failure as first-line treatment in hypoperfusion. If hypoperfusion is associated with adequate blood pressure and signs of congestion. Diuretics in the presence of symptoms secondary to fluid retention, and inotropic agents in the presence of peripheral hypoperfusion and the presence of pulmonary congestion, edema refractory to diuretics and vasodilators at optimal dose. In summary, the heart failure is common and has high mortality. Drug therapy, it improves survival with beta blockers, SC inhibitors, IRBs, and aldosterone antagonists. And the newer device therapy are showing promise for symptom relief and improved survival, like CRT, ICDs. And the cardiac transplantation remains rare, but technology for mechanical assist devices continue to improve. At this point, I want to say thank you, and as usual, take care. Now, I'm ready to hear your questions. If you have the questions, you may ask me.